Good afternoon, ladies and gentlemen. We are sorry for this slight delay, but I'm sure we'll catch up. Giulini will do a very nice scan. I just saw the baby lying in a perfect position. So this meeting will be now about congenital heart defect from first trimester to postmortem imaging. It means there is also some problems in, as you see here, to get a postmortem image at the end of the day. And Giulini Carvalho, my co-chair, is going to join me soon, but she's now behind the stage having a live demo. Do you hear us, Giulini?
Yes, I can hear you, Rabbi.
Okay. So.
Good afternoon.
Okay, good afternoon. Hi.
Are you ready?
Images. You do now 3D of the face. Your topic is the left heart. So please start.
Right, so I'm going to start on a more general approach, just so people can follow how this baby is. And I'm starting the lower maternal abdomen here, where the fetal head is, so that everyone can get orientated. So the spine is to maternal right. So our orientation is that the left side of the fetus is uppermost. And then this kind of keeping the screen wide as well. You can look for a position where the ultrasound window will allow you to see the fetal heart more clearly. See that I'm keeping my screen quite wide just to have a general view and set myself a place where I can see the heart. Here is quite good, so I'm going to narrow the sector to there. We know that the heart is on the left now because we've identified the fetal eye. So I think I chose to concentrate on the left heart because of the presentations that are coming afterwards. So if we turn around here, heart is on the left, and we're going to identify the various structures. So this is the left ventricle. If we start from the abdomen, the stomach is on the left. That's the aorta to the left, the inferior vena cava to the right, which tells me that the atrium on the left is a left atrium. And on that, I can see in here pulmonary veins coming into the left atrium, the foraminal valley with the flap valve. And we have to identify the ventricle attached to the left atrium. And you can see nicely here the offset of the atrioventricular valves. I'll just scroll this down a little bit with my pointer. So you can see very nicely the flap movement. You see nicely the offset. This lady is about 23 weeks of gestation. So the images are quite clear. And you can assess the contractility of the left ventricle visually. You see the mitral valve here. And I think I'm going to start perhaps with an M mode, just because the baby's in a reasonable position for that. And I think a lot of people have trouble sometimes. Just need to zoom it a little bit in identifying what you see on the M mode. I just want my pictures, my M mode a little bit bigger. Right, I'm going to freeze it there. Can we make this bigger here?
You can do a zoom first and then come in.
Yeah. Let me zoom it again, because I think it's one important point on the left heart where a lot of people have difficulty in understanding this better what the M mode represents. So the baby's just starting to kick. A bit more of gain on the M mode. It's waking up this baby. Need a few frames. That more or less would do. It's not a perfect M mode, but will illustrate the point I'm trying to make. I think people have sometimes difficulty in understanding what the M mode represents, and is a good thing for assessing left ventricular shortening fraction, for example. So if you follow that line, we're sampling exactly at that point. And this here, if you put it side by side, you can see that that's the left ventricular posterior wall. So this is the movement of the posterior wall in systole and diastole. This corresponds to the ventricular septum. And that's the right ventricular free wall. So visually, you can correspond each point on the 2D image with the M mode. And from here, once we have a better quality M mode, you can measure dimensions of the left ventricular in diastole and in systole. So that illustrated just the M mode line again. Yeah, my 2D image moved away from there. that to do for our measurements. So in here, although the 2D images come out of the screen, this is the left ventricular free wall in the septum. So you would identify here the movement in systole when the heart's contracting, diastole when it's relaxing. And if you can make measurements here of the widest diameter, which if we have the mitral valve, which is here, you can see when the mitral valve closes, and measure from the posterior wall to the septum, and do the same for systole. And then either use a package on the machine, or you can calculate the shortening fraction, which is the end diastolic minus the end systolic divided by the end diastolic, and you have an objective assessment of ventricular contractility here. Now, if I go back to the 2D, so we can concentrate on a bit more on the left side. And I'm going to start from the inflow into the left side and put some color to highlight our pulmonary veins. And I'm going to start that initially with the conventional color. On the cardiac preset, we would normally start at a velocity somewhere around there, 50 to 60. And I'm going to split the image because I quite like showing it with 2D and with the image at the color at the same time. So if we're trying to see pulmonary veins, we're not going to be able to do that with a velocity of around 60 centimeters per second, which is our scale. So I need to drop the velocity in mid-gestation to somewhere around 20, 25 centimeters per second. And you can see here the left atrium with the atrial, with the flap valve, and you can see the pulmonary veins coming on the 2D, and you can see the corresponding Doppler signal coming from the left lung, showing you a pulmonary vein, and a pulmonary vein coming here from the right lung. There's another one there. And you can see that this is coming indeed to the left side of the atrium, because on the corresponding image you have your atrial septum. So there's no question that this being a superior vena cava, for example, coming to the right atrium. It's quite nicely showing that as well on power Doppler. And again, the same principle applies. You need to decrease your velocity and sometimes increase the gain, just to highlight. And many times the power is much more sensitive to lower velocities. You can see nicely, again, here we see 3 of the pulmonary veins coming into the left atrium. So it's quite a nice demonstration of that. Because you might need to sample the pulmonary veins in conditions like hypoplastic left heart syndrome. So I'm just going to come out of the color and put my Doppler, pulse Doppler. Baby's behaving quite nicely. So if you put a relatively large sample volume, you can pick up, that's the pulmonary artery, and we really want to pick up the vein there. Right, so this is a quick freeze here because I'm not sure if I'm going to get the signal again. But this is the typical signal of a pulmonary artery and pulmonary vein together. And you can access that very easily in a standard 4-chamber view, and you have multiple points of sighting because you have so many pulmonary veins. So it's usually quite easy to get the signal. And this is a very normal signal, and it resembles ductus venosus Doppler signal in a way. You have your S wave for systole, your D wave, and the lower down here is your atrial systole. And to the other side, you have the pulmonary artery signal, because in here where we're sampling, the artery is going towards the lung and the veins coming towards the left atrium. And intraparenchyma, they run more or less together, so you can use the two of them in the same recording, which can be used as well, not only to assess the pattern of the pulmonary venous Doppler signal, which may be abnormal in cases of hypoplastic left heart syndrome, for example, but you can also, in monitoring fetus with anti-Rho antibody, you can measure distance here between the beginning of atrial systole, which is this waveform, and the upstroke of the ventricular contraction, which is here. So I'm just going to measure quickly here the down slope here on the A wave to the upstroke of the pulmonary artery signal, and our measurement there is 139 milliseconds, which is down here, which is a normal AV or atrioventricular interval using this technique. So it's quite a nice way of measuring the AV interval. If I come back to the 2D image, and then go back to the left ventricle. So visually we have a good contractility of the heart. We kind of had an assessment of function. If we put our power Doppler, increase the velocity because it was quite low because I was looking at the pulmonary veins. And if we split the image again, it's a nice way of showing the ventricular septum, go all the way down, scan to the back of the heart, you come anteriorly, you always adjust your hands to see the parts of the heart you're interested in. I'm interested more in the apical position. The fetus is moving. So I'm going to go back to the standard color because I want to see velocities across the inflow and outflow tract. And our standard velocity is somewhere around 50, 60, or 70 centimeters in mid-gestation. And you see nice filling of the left ventricle, which should be more or less equal to the right ventricle. I'm highlighting here the septum very clearly. So you see that in the normal heart, the aorta will come here, wedged in between here, between the mitral valve and the tricuspid valve. So you can easily, if you want to get Dopplers, inflow and outflow of the aorta, you can easily get it here. And if you have an image on the other side, maybe I will come out of this and I will narrow the sector a bit more, because if I'm interested in the aorta and aortic valve, the closer I get to that and the bigger I make it, the more details you can get of what you're interested in. And if you're interested in particularly in the aortic valve, then you'll come out of the zoom just a tiny. And then you can freeze and look back at that left ventricular outflow tract, where you have here a continuity between the septum and the aorta. That's the aortic valve. And you can see this tiny little thing here is the aortic valve closed, and it's very thin leaflet, so you only see a tiny echo in the middle. And you can slowly scroll your machine, and when that echo disappears, there is when the aortic valve opens, and you see it closing again, and you see it open, and you see it close. So that's the normal appearance of the aortic valve. So if you come out from that, I'm not quite sure how I'm doing for time. I'm just going to show how relatively easily one can get from that short axis planes, axial planes, to a sagittal view. But I'm going to do a sweep between, open the area a little bit more because we want to pick up the 3-vessel and 3-vessel trachea view. And I'm going to put the color so that you can appreciate it both with and without color. So slow sweep between the 4-chamber, and you get the aorta in the middle. And then as I go more towards the baby's head, which is lower down, you're starting to see the bifurcation of the pulmonary artery. And then further up, we get the pulmonary artery. And then we come up to our 3-vessel and 3-vessel trachea view, where we see very nicely here the transverse aortic arch with the trachea to the right, the superior vena cava, aorta, and the pulmonary artery in a nice alignment, showing normality here. And then from this, if you can obtain this view here, you can very easily just rotate your hand around that plane. I'm going to come out of color, make it a bit wide so you can see what I'm doing. It's not the idea for scanning, so just that you can appreciate the movement. So if you can get the aortic arch like that, you can just rotate around that plane, always twisting your hand in all sorts of planes. And usually here, you get a nice view of the aortic arch, which is coming up. There we are. So when you start to get that view, you can narrow your sector again. So you can do a sweep between the axial view and the sagittal view. And I'm going to put maybe a power Doppler there. Increase that box a little bit. Oops, sorry. There we are. Maybe split the image, and you have a nice aortic arch. You can also see the inferior vena cava. That's the right heart. So you can see from this plane as well, you can assess the left atrium here. The left atrium is behind. It's behind the aorta, and it's more posterior than the right atrium. So we've got here the superior vena cava, the inferior vena cava, the right atrium. We've got the flap valve or the foramen ovale, the left atrium behind. So if you want, you can look at the pulmonary veins from that angle as well. You can see them coming in here from the lung. Yeah, pulmonary veins into the left atrium. So it's a different way of looking at the left heart. So the other point I want to make, if I still have time, is that we started over here, which is where there was a good window to see kind of an apical four-chamber view. You see that I ended up moving the maternal abdomen lower down, which was much down here. So quite often, don't be put off by having the fetus in this position, because, let's put a bit more again. Yeah. Usually, if you have this spine on the top, not exactly at 12 o'clock, but you can always move it a little bit to one side. So if this fetus were in this position, which I'm just making it to be in this position because I've gone right into the right side of the maternal abdomen, it's usually relatively easy to get through here. And you can see how clear the image can be even if the apex is not pointing upwards. And if you have the fetus in this position, it's actually from here, it's almost dying to say you turn round and you can get the aortic arch here. And it's very easy to do that from that view. So you can very easily get your aortic arch from a position where the spine is on the top, so you don't always have to come from the front. And in this angle, either from this side or the other side, you usually can. Actually, in a way, the quality of the image coming from the back here is a bit better than it was because we're closer to the fetus. To get the other one, if I just keep it down, just need to think about some of these kind of technical details. In here, the spine is on top, more or less here, but I'm closer to the fetus. While if I go through here, I get the fetus in a good position, but you see I have to change my depth. And therefore, although the baby is in a better technical position here, I'm a bit further away from the baby because the chest is down here. So if I come here, I get a bit more resolution, even though the spine is on the top. And I quite like scanning the baby from this angle, to be honest. You can see take away that arrow away. You can still see all the details, not only the left heart. Yeah, so you can see that flap valve beautifully there. See the foramen ovale, you see the offset, the mitral valve opening and closing. It's just going to move. So it's quite a nice view as well to show you the septum, the septo-aortic continuity. I'm going to increase the scale a little bit, split the image. So from there you can scan from the abdomen, slowly coming up, and you see the very back of the heart, the more posterior part of the septum, and you can stop and see that the ventricular septum is intact and its inlet portion. And then as you tilt towards the left ventricular outflow tract, you see nicely here the left ventricle with the aorta coming up and the aortic valve, so a nice septo-aortic continuity. And your right ventricular outflow tract is going to come here, but you see you're already seeing some of the pulmonary bifurcation there. And as we move up, you're getting your bifurcation of the pulmonary artery. So this is on the right side of the heart. And bifurcation here, the right and the left. The duct is going to come in the middle. There it comes. Then you get your aortic arch. So it's a very well behaved baby, this one. But you can see that sometimes it's worth coming from the back rather than from the front if the fetus is closer to the transducer, because the depth might overcome the position. And I think these images are quite clear. Is there anything else it's not clear?
It's perfect, Julene, thank you. Are there any questions from the audience, something you wish to see? I think you showed us clearly everything, and then we thank you and we thank the patient very much. And please join me that we can start with this session. Thanks very much.
Thank you.